It's a great pleasure to welcome to our webinar tonight, Dr. Shouresh Charkhandeh, who was with us in person in 2018 at our second last meeting in Toronto, and then of course COVID hit. And so we're glad that he's able to be with us. He's a very busy man. I'll give you his bio. As a well-known and passionate educator and underlying passion, you'll find that tonight if you've not met him. Researcher and innovator in dental sleep medicine, Dr. Charkhandeh has lectured at numerous national sleep meetings across the world, including Canada, USA, Belgium, Netherlands, Germany, Italy, Puerto Rico, and Brazil, and has trained over 1,000 dentists in this field over the last decade. He is the recipient of the 2012 and 2015 Clinical Research Award and the 2015 Clinical Excellence Award from the American Academy of Dental Sleep Medicine. He's a general dentist who received his dental degree and his degree of Bachelor of Medical Sciences from the University of Alberta. He then furthered his education training by completing a research fellowship in the area of sleep and dental sleep medicine at the University of Antwerp in Belgium, where he's currently working on it. You ready for this? His PhD, and I'm sure you'll talk about that as well. He's the founder and director of the Alberta Dental Sleep Medicine Study Club, the clinical director at the Snore Center in Canada, and has served on multiple different advisory boards related to dental sleep medicine. He serves as a global scientific committee chair for Prosomnus Sleep Technologies. His topic tonight, precision dental sleep medicine, the impact of precision mandibular repositioning devices on clinical care and treatment efficacy. Dr. Charkhandeh, welcome back to our academy. It's all yours.
Thank you, Dave. Thank you for the kind introduction. And it is, of course, a pleasure to be back. Want to welcome everybody. I know people are slowly coming in. I see some familiar names. That is fantastic. Hopefully, I'll get to see their familiar faces as well when we get to the Q&A section when they turn on their videos. It's about 5:37. I do have about 45 minutes, 40 to 45 minutes worth of slides. Maybe I'll go through them a little bit faster so we're not going to stay up too late tonight. With that being said, I'm just going to get right into my conflicts of interest. I am an advisor to Prosomnus Sleep Technologies, as you mentioned, Dave. So that is the only conflict that I have for tonight's talk. As a introduction, as a kind of a review, let's talk a little bit about sleep apnea, right? We understand that there is about over 1 billion people in the world, based on the research data, that suffer from obstructive sleep apnea, and there is over 3.7 billion people that actually snore. It's a very big figure. It's a very impressive in some ways number, but what's even more concerning is the fact that 80% of these patients are still undiagnosed. So anytime we're talking about a sleep apnea or any related topic to this field, we have to always keep in mind how early we are in this field. If we compare that, for instance, to hypertension or diabetes, 70 to 80% of the patients with these chronic disease are already diagnosed. But when we look at sleep, 80% of the patients are still undiagnosed. So we're just scratching the surface. This is just the tip of the iceberg, and whatever we're talking about, we have to make sure it's going to be scalable as we look at the future of this field. We understand sleep apnea impacts our health. We know it impacts our physical health, increases risk of heart attacks, strokes, diabetes, impacts our fitness and BMI, and fitness, all obviously they in fact our sleep apnea as well. It has a huge impact on our mental health, close relation with Alzheimer's disease, depression and anxiety and dementia. And it does impact our work and economy, and never mind our day-to-day life as well. In the past decade, we also learned that it has a huge impact on dentistry. So whether or not you are a dentist who's interested in doing sleep medicine or not, in a way, sleep medicine is not leaving us alone. We understand the correlation between sleep apnea and bruxism, big correlation between sleep apnea and periodontal disease, orthodontics and pediatrics, implant surgery, TMD pain. So it kind of touches every aspect of dentistry that we do day to day. So for those of us who is on the call today or watching this later, if you're a dentist and you're just thinking about getting into this, As I always say, is if you want to do comprehensive dentistry alone, you need to learn about sleep. You need to learn about dental sleep medicine. What is the solution? What is the solution for this chronic disease that is impacting the world? Well, the solution happens to be a machine called CPAP. It's been around since 1981, saved millions of lives, tens of millions, hundreds of millions of lives probably. And when we start looking at the problem with CPAP is the fact that is the go-to treatment, which happens to be CPAP, is not well accepted by the patients. So a lot of patients do not want to wear this device. Over 50% of patients are non-compliant or non-adherent, for a better term. So we have all these patients that get the machine, but they don't end up using it. So we got to look for an alternative. And what is that alternative? That alternative happens to be oral appliances, which if you look at the meta-analysis of the research that is present in the field, 60 to 70% of patients will respond in terms of response to sleep apnea treatment. And when we're talking about complete response, we're talking about reduction in AHI, in baseline AHI of more than 50% and getting below 10. Oral appliances are preferred by most patients. Compliance is much better. But when you start looking at the utilization of this treatment, we realize it's only utilized in about 5 to 10% of total OSA therapy. So one might ask, why are oral appliances so underutilized, especially if they can be used in 60 to 70% of patients? You would think there would be more than 5 to 10% utilization rate. Of course, if you look at different markets, if you look at certain pockets in Europe, they're used as high as 50%. But then there are other pockets that are only being used 2% or 1% of the total OSA therapy. Well, the reason for that is oral appliance therapy has its own challenges as well, or I like to call them perceived challenges. Patient selection is always a problem. We don't know who these devices work for. Measures that looks at the severity of the disease and their AHI based for patient selection are not as accurate. We've learned that over the last few years. Titration protocols. This is the movement from that starting point to the point that the patient is fully treated. There is no standardized titration protocol. American Academy of Dental Sleep Medicine came up with a paper a couple of years ago, I think it has been now. And if we look at that paper, we realized how diverse and how different protocols are as of today. So time to efficacious treatment. The patients sometimes take a long time before they're effectively treated with this therapy. And accuracy of bite transfer, that is basically the position that we're putting the jaw in order to get rid of their sleep apnea, in order to keep an open pharyngeal airway, is not standardized either. So efficacy becomes a problem as well. So how could we improve? That's the real question, right? We have such a good therapy that could effectively be used in 60 to 70% of patients, and we'll come back to that because new data shows that it could even be used in more patients than 60 to 70%. But how can we improve? We'll come back to that question. When we look at the titration protocol, here is a graph from our study from a few years ago when we looked at the amount of protrusion required to treat patients with oral appliances. And as you can tell, there is a wide range. On the bottom, on the x-axis, you see the amount of the percentage of protrusion that was required for the patients to be effectively treated. And on the y-axis, you see the number of patients. And when you start looking at that, you realize there is a big range. There's some patients that don't require almost any protrusion, and there are some patients that require almost 100% protrusion. So starting at, for instance, at a place that is 60% of protrusion or 70% of protrusion may result in over protrusion of some of these patients. And starting them way too early as well, sorry about that, may result in frustrated patients that are not going to be treated effectively in a reasonable amount of time period. The other problem with titration is the multifaceted nature of the titration. What do I mean by that? Well, when you look at titration, we're trying to accomplish many different things, but mainly three things. We're trying to get a reduction in AHI, apnea-hypopnea index, or ODI, hopefully by greater than 50% and below 10 from the baseline. We're trying to get an improvement in subjective signs and symptoms of the patients. And while we're doing that, we're trying to minimize the side effects. The problem is these three different facets, when you look at it, they don't respond similarly to titration in terms of that anterior-posterior movement. So what we do know is the more you protrude the patients, the more AHI reduction you're going to get. But the signs and symptoms, there is no correlation between that and AHI. And the side effects could, of course, increase as well. The next slide actually shows a few different impacts of protrusion on different aspects of titration. So the study that we have on the far left, it's the Cato study from 2000, which is showing that the more you protrude the mandible on the x-axis, there is more chance of AHI reduction. At the same time, as we're reducing the AHI, as we're moving forward on this protrusion, we are increasing the risk of side effects as well, which is not a good thing because more side effects means possibly less adherence to therapy. And this is exactly what the last slide, the study with the Router group out of Netherlands as well in 2020, showed that the more advancement that we have, there is more side effects and there is less adherence from the patient. So we got to be very careful. Basically, the take-home message is where we're putting the mandible, where we're positioning the bite, and how are we doing our titration? How are we getting to that final point where the AHI is within acceptable limit, where the side effects are managed, and where there is not a lot of patient concerns in terms of comfort, okay? And when we start looking at it from the device manufacturing perspective, which is the topic that I do want to kind of zone in and focus on tonight, if the bite position matters, if it impacts efficacy, then the device manufacturing goal should be maintaining that position that is being given. I like to call it the dosage of the therapy, the amount of protrusion that is required, the bite registration that we take. If we're giving to that position to the manufacturers, we have to make sure that position is being maintained. So it should be maintaining that prescribed position in manufacturing and during sleep as well. We got to make sure the devices are maintaining that position and they're not losing that position due to mouth opening or to other factors. We got to minimize disturbance to physiology. We got to make sure these devices are anatomically shaped. They're going to be comfortable for the patient. They're not causing arousals, and minimize introduction of new factors such as side effects and allergies. In my opinion, that should be the goal of device manufacturing in today's dental sleep medicine. So correcting the anatomy while minimizing the side effects overall. Let's start with bite registration. So when we're talking about that position, the first thing that we do is we do a bite registration. And once we do a bite registration, basically what we do is we're determining a position, for lack of better explanation, in which we take into consideration the muscles of the mastication and the orofacial muscles. We want to find a position where these muscles are comfortable relatively, they're in balance with each other. Some people use the terminology physiologically balanced position. We want that position to be in a place that the joint also is comfortable. We want to make sure the joint is properly loaded. There is no issues on TMJ. It's a symmetrical protrusion. And while maintaining those two factors, we got to make sure the most important thing is taken care of, and that's our passive pharyngeal airway. We want to make sure the airway is optimized and keeping the airway open. That's the goal of bite registration when we do a bite registration. So finding a position where the muscles and joints are comfortable and the airway is going to stay open. Of course, this is an oversimplification. And when we're talking about the joint, obviously here, as we can see a few different images, there are videos. I'm not going to play them just in case they're not going to play properly on the presentation. But on the top left, you see a properly located joint where the meniscus is sitting on top of the condyle and the joint is loaded. On the top right, you see an anterior disc displacement. And this case is with reduction. That means that as the joint is opening, the meniscus goes on top of the condyle. And the next is anterior disc displacement without reduction and all the way to degenerative joint disease. So anytime we do a bite registration, we have to keep this in mind and we have to try to accomplish that top left picture, hoping that the joint is going to be properly loaded. I think that's one of the biggest mistakes that I see the new people in dental sleep medicine, they take when they start taking the bite. They don't pay enough attention to the joint and how it's being loaded, which can create a lot of issues in terms of lateral position of the bite and possibly even further breakage of the devices. So we do the bite registration, we make sure everything is perfect, and then from there on, we either do a digital or manual transfer of this byte registration to the manufacturers. That means that we either send the physical byte that we took to the manufacturers, or we go ahead and we do a scan of that byte, which is research is showing is a lot more accurate way of transferring the byte to the manufacturers. Once this data reaches the manufacturer, there is two processes that are available in the market today. One is CAD/CAM, precision and very accurate way of transforming that byte registration into a device with the use of milling, printing, and all these different technologies. Or we have the old way of doing it, which is pouring the models, mounting it on the articulator, and using a pressure cooker and making the device. What the data shows, unfortunately, is the moment you look at the devices that are available in the market today, we see a big range of accuracy. Some of the devices, where the device is positioning the mandible, is very close to where the actual byte registration was, within 0.5 millimeter accuracy. We call it a global variance from the byte registration. However, some of the devices, some of the manufacturers, you can see as much as 6 millimeter global variance. That means that wherever you took the byte, wherever you spend the time as a clinician and registered the byte, it may not even be close to the appliance that you got back. It may be 6 millimeters, 5 millimeters, 3.7 millimeters away from that position, which raises the question, then why do we spend any time on making our byte registrations accurate? If the manufactured device is going to be so far away from what we've sent to the manufacturers, it always raises that question. The other thing that we got to keep in mind is, of course, the titration mechanism. I'm using 2 here as an example, could impact the position of the actual mandible during the evening, during the sleep hours, I should say that, not the evening per se. For instance, here we see a device with a 90-degree angle, where we do know it protects that position with a lot more accuracy versus a device that has 70-degree angle, which allows the jaw to fall back as the jaw is relaxing. Of course, there are devices that have anterior hinge, which tends to hold the jaw even better. There are devices that have a band, which is whether retraction or pushing the mandible forward. So what a clinician should do, we should pay attention to those and keep in mind that the position, again, the byte registration that we are taking may not necessarily be the position where the mandible ends up being when we get the device back, whether due to the reason that the device wasn't made to that position or due to the fact that the jaw is opening and relaxing and falling open from that position. These are the things that impacts our titration, because if you're not getting the results that you're looking for from the device, we're going to sometimes just excessively titrate the mandible forward, thinking that the answer happens to be in a more protrusive movement. So beware of that. And why does it matter? It does matter in today's dental sleep medicine, but it matters even more if we're planning on treating more patients. If we're seeing 10% growth, let's say in North America, if we saw 50% of patients on oral appliances, that's a 10 times growth in dental sleep medicine. As I say, this is not unheard of either. When you look at markets such as Sweden, such as Netherlands, they are already doing about 50% oral appliances. Then we need to make sure our systems are safe. They got to have a good confidence interval, and they got to be simple and predictable. What do we need? As I said, accurate, predictable workflows, more efficient device manufacturing, and more importantly, we got to be able to expand the access to care. We have a lot of patients. Remember, 80% of these patients are still undiagnosed. So we got to be able to provide this treatment more effectively. We got to get more dentists involved. We got to be able to diagnose more patients and be able to help them more. What else do we need? If we're going to increase the access to care, we got to need improved and precise screening. We got to get better with our screening to be able to find more patients. We got to do a better job of diagnosing. Our diagnostic tools today, although they are coming a long way, we moved away from level 1 to level 3 testing, but even level 3 testing is putting a strain on the amount of diagnosis that is available to the patient. The good thing is, even in that area, we're seeing a lot of new technologies that are coming out that is making the sleep testing even easier, which would in turn hopefully increase access to care. We got to do a better job. We got to improve our patient selection. what patient goes on what treatment. We need better algorithms. We need better clinical models that would allow us to choose the right treatment for the right patient. And obviously, as we just discussed already, we got to have better device manufacturing, which means that our device manufacturing level of confidence, or the confidence interval, should match the same as our clinical confidence interval. You're only as good as your weakest link, right? If you do a great clinical work, but device manufacturing is not up to par, it doesn't mean that you're going to have the same results in your therapy, and vice versa. You can have the best devices out there in the market. However, if the clinical workflows are not well established and evidence-based, we're not going to get the same results. Short-term management, long-term management, we got a lot of work to do. We got to start looking at oral appliance therapy in a different way. And in my opinion, we're in the golden eras of dentistry today. The digital revolution in the dentistry in the past decade has been nothing short of just marvelous. You know, the CBCT technologies, the digital scanning, and a lot of these technologies have been available for a long time, but they were not as readily available, and not a lot of dentists were using them. I remember 2010, 2011, when I was lecturing, you would ask people how many people have an intraoral scanner. Maybe 5 to 10% of the dentists would raise their hand. Today, if I ask the same question, we end up getting 60 to 70%, if not 80% of the attendees raising their hand. So we are seeing that digital revolution in dentistry, and we need to apply that to dental sleep medicine. We need to use the tools that is available to us, that is improving our accuracy, that is improving our precision, to be able to get better results. We did a study back in 2015. It was a feasibility study, and we followed that by a few other studies, which we looked at a digital workflow for oral appliance therapy, and that was including the device manufacturing. And what we found was the results were a lot more superior to the traditional workflow models. So in a way, we're moving towards what we like to call precision medicine. What is precision medicine is basically the tailoring of medical treatment to the individual characteristics of each patient. This is a huge topic on its own. We can spend hours talking about this, but this is the era that both the systems and the patients and the clinicians are demanding a certain level of precision, a certain level of personalized care. So what would it look like in oral appliance therapy if we're talking about precision medicine? Well, if we were going to take a crack at it and kind of give it a little definition, it would mean that tailoring of oral appliance therapy to characteristics and anatomy or phenotypes of these patients, inclusive of diagnostic tools, wide registration, oral appliance therapy protocols, and everything. So it would result in more efficacious treatment, fewer false negative outcomes, better treatment adherence, hopefully minimizing this unwanted side effects. And this kind of brings me to the dental sleep medicine evolution. If you look at the history of dental sleep medicine, the first era, in my opinion, was that proof of concept. This is in late 90s, where we were just utilizing these orthodontic devices, in a sense, for the treatment of these patients. It was validated as an alternative to or a CPAP. It was basically looked at as a rescue path, as a waste basket. But it slowly became more common. More people started doing it. More people started using it. So the medical field started hearing more about it. And in 2005, the guidelines came out, and it started looking at it as the first line of therapy for mild to moderate sleep apnea, and as an alternative for severe patients that are not going to use their CPAP or prefer oral appliance therapy. And that was the point that we started seeing huge increased adoption in this, and a lot of dentists started getting more involved. It was a huge commercialization of dental sleep medicine, and we saw more patients, more dentists getting involved in it. We had further scientific advances. If you look at the number of papers over the last decade, we see this really exponentially growing number of research studies that is being done in the field, and it started grabbing a lot more traction. So what's next? And I think, in my opinion, next would be looking at oral appliance therapy as first line of treatment for sleep apnea. I know it may sound like a big dream, especially in North America, where we still are struggling with some of the physicians accepting oral appliance therapy as an alternative, never mind oral appliances being first line of treatment. Especially with the way we're going, with the way we're seeing oral appliances treat patients, the patient preference, the adherence, the mean disease alleviation, which is the effectiveness of the treatment being superior to CPAP, it's not far-fetched to look at oral appliance therapy as being first line of therapy for sleep apnea. But before we get there, we need to increase our accuracy and precision in different areas. As I said, we got to start moving away from the conventional sleep tests. We got to start looking at new technologies. Just a couple of days ago, we got a new article about the new device that got FDA approval from Sunrise that allows you to diagnose sleep apnea technically with a little sticker that just goes on your chin. What is so cool about these technologies, as I said, it allows access to care. It allows for ease of testing. It allows for patients being able to easily access these technologies without having to go through the same medical model. Medical model is great, but it does create quite a bit of a strain on access to care at some times. Data interpretation, human versus machine. We're seeing a huge increase in machine learning algorithms in looking at PSG data. We need to improve our clinical diagnosis. What is our clinical experience and bias? As a dentist, we all have bias towards appliances. As a medical side, we have bias towards CPAP. We got to start looking at these a lot more closer and start improving all of that. The goal would be improving our diagnostic accuracy. Treatment selection is a big topic. Is it clinicians? It's being affected by clinicians' choice or bias. It is being impacted by patients' choice or bias. Clinical indications, non-clinical factors such as cost. These are all the things that we could start looking at algorithms that would predict all these and be able to allow us to look at a patient and based on a simple questionnaires, figure out perhaps what treatment is best suited for that patient long-term. And of course, bite transfer and device manufacturing, as I spoke about that, that's a topic close to my research, close to what I always believed in, and that's utilization of technology to improve the accuracy of these devices. If we can do that, perhaps we see even better results. Maybe we can treat more than 60 or 70% of the patients. Of course, calibration, titration requires improvement and the validation of the actual treatment. Are we looking at AHI? Are we looking at other factors such as oxygen-based parameters that is going to let us know if the patient is treated? Are we looking at one night of a study or are we looking at 2 nights of a study because of the night-to-night variation? Or do we need to look at what we call continuous monitoring of these patients, similar to what we see in diabetes model, because these patients are sleeping every night and we're dealing with a chronic disease in a sense. It sounds like a very complex concept, I understand. There is a lot of challenges. Some of these areas we have the tools that we need. Some of these areas we don't have the tools. There's of course the question of ethics always. When we start talking about machine learning, artificial intelligence, there is a lot of questions around the ethics of that. Is it ethical to use these technologies? What about the patient data? What are the factors that we got to keep in mind when we look at the patient data? Cost becomes an issue. Sometimes these tools tend to cost higher initially, although in the long-term models usually tends to end up costing less to the system. So these are the things that we got to consider. Again, I don't have the answer for all of them today, but what I'm trying to get at is just raising the question and raising the bar, making us start looking at dental sleep medicine with a different set of eyes, with a different set of glasses, looking at it in terms of it being the first line of treatment. What do we need to do to be accepted as first line of treatment, not as a wastebasket, not as an alternative? The good news is, even with the limitations that we have today, we're still helping a lot of patients. All of us that are on this call, or some of you that are just getting involved, we are doing a great job. We're helping many patients, whether we are lucky, whether it's coincidence, whether it's compensation of errors with all the errors that we're looking at, whether it's tolerance of errors with this is human physiology, I don't know. But we do know is we can help patients even with our, what I like to call subpar protocols that we have as of today. And hopefully it's going to change. Hopefully more research is going to help us become more precise and become more evidence-based in our oral appliance therapy. But that being said, we've done some research in the past 5-6 years, and we tried to kind of imitate these models. What would happen if we looked at a optimized workflow that utilized patient selection tools. That is, of course, when the FCMP technology was still, RCMP and FCMP technology was still available, and utilized digital workflow with precision device manufacturing. And we looked at what would that result in terms of the final efficacy of the outcome and final response to oral appliances. So the purpose of this study was to demonstrate the efficiency of a completely fully digital workflow. We systematically pre-selected those likely to respond to oral appliances. We accurately captured their bite at a position. We translated that bite into the digital device, into a digital impression for a precision appliance. And then our goal was to establish efficacious treatment very quickly with minimal titration and improvements to challenging step of digitization. What the results that we looked at was we managed to get majority of patients, 86% of patients treated from night one with this treatment protocol, where we knew if they were going to respond to oral appliances, we knew where to set their jaw, and we actually translated that into that position utilizing a precision process of capturing the device. About 4.2 days in average from mean days of insertion to effective treatment. And within 20 days, within 3 weeks, all of these patients had their HSAT as well. This isn't compared to 3 months or 6 months of titration that we are spending in our clinics today. So a huge change. But what was also very interesting in this study, when we looked at it, we realized over 81% of our patients responded successfully to oral appliance therapy. This was a huge jump. This was a huge difference. When you look at the meta-analysis, and in average, it's showing about 67% response to oral appliances. 81% was a huge change from what we are used to. And the question is why? Is it because of the precision steps that we're taking here? Sorry, I said 65, I meant 55%. There was a 26% gap between the efficacy. That means that when you look at the meta-analysis from the last few years, from the last few decades, what we're learning is 55% of patients, that's what you hear, respond to oral appliances. But maybe some of us are experiencing this in our clinic already, that we have higher effectiveness, and that is 81%. In general, there's the other thing that I want to look at and I want to talk about is about how about severe patients? Oral appliances are not looked at favorably for severe patients too much. What kind of results can we get in severe patients if we followed this precision protocol? And the answer was, again, quite eye-opening for us. In the moderate range, 87% of patients responded to oral appliance therapy if you looked at REI of less than 15 as response rate, and 68% of severe patients responded to oral appliance therapy successfully. These are a lot higher numbers than what the standard averages are today. And when you start looking at the data since 1999, what you're seeing here is year of publication of the papers. So we looked at all the papers that came out in terms of the efficacy of oral appliance therapy on mild to moderate OSA. And you start looking at it, in average, we have about 74% response rate in mild to moderate cases to oral appliance therapy. But what's important to recognize in this graph is the fact that what we're seeing is, since 1999, the efficacy seems to be improving with time. So why? Is it because we're using better protocols? Is it because we're using better devices? Is it because we have better clinicians with more experience? Is it because, I don't know, there's more patients, we have better data? Well, the answer is probably all of the above, right? But it is very obvious when you look at these graphs that the efficacy rate from 1999, for instance, until 2002, if you look at those papers, it was only 64%. If you look at the papers from 2005 all the way to 2016, the average would be around 72%. And if you look at the papers for the last 5 years, for instance, the average is about 86%. So we are getting better. We are getting better and better with time, with the improvements that we're having in our devices, with the improvements that we're having in our clinical protocol. But I personally don't think we're there yet. I think we can improve even further with the technologies. If you looked at mild to moderate, as I said, we are improving quite a bit. And if we compared the precision manufacturing and the precision protocols to traditional models of the dental labs, we're seeing a big gap there as well. If you look at the papers that utilize precision devices and precision protocols, digital workflows, our rate is as high as 92%, where in the traditional model, we're looking at about 75%. And in the severe range, it's very similar. There is a big gap between precision versus traditional way of doing oral appliance therapy. So at this point, what are the clinical benefits of this improved way of doing oral appliances? And to me, it's pretty obvious. For clinicians, we have fewer adjustments, fewer titration appointments, fewer repairs. These are the things that we always wish for. Chair time savings, better relationship, better confidence with referring physicians, better relationship with patients. And from patients' perspective, there's more comfort, less time in therapy, better outcomes, more confidence, perhaps better adherence to treatment. So we have a lot of improvement in terms of what we can accomplish here. So the real question that happens, and I want to leave everybody with here, is what we got to ask ourselves today is, are all oral appliances the same? I know we've been taught that for many years. That's what I taught to my students for the longest time, that your body doesn't know what type of acrylic do you have in your body. I'm sure some of you have heard that before. But the newer research tends not to agree with that. And it seems like maybe it does matter, and maybe our body can differentiate where the jaw is being positioned and how it's being positioned and how it's being held in that position. What does that mean? We don't know today, but it's something that we really have to study further. We have to study it in more depth, perhaps run more studies that looks at this in a head-to-head kind of a comparisons, and start looking at different classes of devices and not putting all the devices in one basket. It would be almost, to me, putting a non-custom device and a custom device in the same basket. And I know that sounds quite crazy to everybody on this call, but what we're doing today, in my opinion, is not far from that if we're considering all the devices the same. And start focusing on how do we make our oral appliance therapy protocols more accurate in the hopes of achieving that precision dental sleep medicine, which is better screening, better diagnosis, patient selection, better device manufacturing, better protocols for our clinical workflows, short-term management, long-term management, endotyping, phenotyping, all the topics that we're hearing about in sleep medicine today. That's very, very relevant. And that's what we're hoping to achieve in the next few years, hopefully. What is the future of oral appliance therapy? That's the main question. Is it going to be what we've done in the past decade, or are we going to start looking at the devices differently and start looking at therapy differently? Are we going to start looking more at oxygen-based parameters for diagnosis and for outcome assessment? Are we going to look at, as I said, monitoring the patients closer? Are we going to look at perhaps having different classes of devices, whether digital workflow and digital technologies are being used or not? This is a very exciting time in oral appliance therapy. It could be very easy for us to think that, well, you know, we've done it all and we know it all and this is it. But I feel like the next few years, we're going to see so many changes, as we were starting to see some of it already with regards to precision and digital workflow and how that could change the way we do oral appliance therapy. One of the technologies that is quite up and coming right now is printing, of course. How nice would it be able to print a device the same day that your patient comes to you for therapy and not to have to wait 3 weeks? Remember, we're dealing with a life-threatening disease. How nice would it be for the cost of the device to be lower? How nice would it be to be able to monitor your patients every night? A lot of things that we always perhaps didn't even think about are becomes things of availabilities, and perhaps that will make us change the way we look at our oral appliance therapy and the protocols with that. I'm going to leave it at that. I'm going to leave it up for questions, because I'm sure there will be some questions that it's going to challenge some of my statements. I look forward to those, of course. But what I want to leave everybody with is we are at a very special time when it comes to oral appliance therapy. I feel like we're just scratching the surface, and there is a lot of exciting developments coming down the pipeline. And hopefully we'll see a lot more dentists getting involved in here as well.